Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Pfizer.
This program is presented by Medscape Education Global.
Well, hello everyone. I'm Ziad Al-Ali. I'm a senior clinical epidemiologist at Washington University School of Medicine. I'm also the director of the Clinical Epidemiology Center and the Chief of Research and Development at the VA St. Louis Healthcare System. And I want to welcome you today to our program entitled Long COVID in Context, a closer look at the post-viral syndrome and management approaches. And I'm very pleased to be joined today by Professor Bin Sao, who is Vice President and Director of the Department of Pulmonary and Critical Care Medicine at the National Center for Respiratory Medicine and the National Clinical Research Center for Respiratory Diseases at the China-Japan Friendship Hospital in Beijing, China. A very, very warm welcome to you, Ben. And today we're going to start by providing an overview of the current understanding of long COVID, including its various phenotypes, its prevalence, and the significant burden associated with it. We will also discuss the different treatment approaches used for patients with long COVID, including potential role for antivirals in preventing and managing this very challenging condition. So I'm going to take you back to the beginning of the pandemic. In the very, very early days of the pandemic, patients who had SARS-CoV-2 were starting to report to us that long after SARS-CoV-2, the acute phase of SARS-CoV-2 has resolved, the fever and the cough and all the acute manifestations, they were left with myriad symptoms that they couldn't explain. And those included weakness, fatigue, brain fog, muscle problems, joint pain, and many, many other manifestations. And to their credit, the patient community actually started referring to the condition as long COVID and started referring to themselves as long haulers. So if you think about it, the very, very early reports of long COVID did not come from physicians or physician scientists or research labs, but it came from patients themselves who alerted us that they actually were not fully recovering from long COVID. So what is long COVID? So we actually decided to address this question very early on in the pandemic using a high-dimensional approach, an unbiased approach, looking at the different manifestations that could result after an infection with SARS-CoV-2. We saw that in the 6 months that followed the initial acute infection with SARS-CoV-2, some people were left with residual or ongoing problems in mental health, in nervous system disorders, metabolic conditions, gastrointestinal conditions, skin disorders, coagulation problems, blood clotting, cardiovascular disease, respiratory disease, some patients with kidney problems, musculoskeletal conditions, and other manifestations. So that's really what long COVID is. Long COVID constitutes the post-acute or long-term health effects of SARS-CoV-2. And we wanted to sort of try to understand it in the broader context. We wanted to understand it vis-a-vis a respiratory viral illness that we actually have known for a long, long time called the flu. It comes around every year. It infects a lot of people in the US, a lot of people around the world. And we wanted to comparatively understand, the post-acute sequelae of SARS-CoV-2 versus seasonal influenza. What we saw at the time that the post-acute manifestations of SARS-CoV-2 or what we call long COVID, their magnitude of risk is higher in SARS-CoV-2 than seasonal influenza, and the breadth of organ dysfunction is much more extensive. So we concluded at the time that this is really a different kind of post-viral syndrome. We also noted that the risk was not confined to only individuals who were hospitalized at the time who had severe disease, but it was also evident in people who had mild SARS-CoV-2 infection. And this is really important because most of your patients, most people around the world actually get mild SARS-CoV-2 infection. Very few, luckily, fortunately, very few only end up with severe disease necessitating hospitalization or an ICU stay. So fast forward to about a year ago, there were two reports that came out from the National Academy of Sciences, Engineering, and Medicine in the United States. One report cataloging the long-term health effects of COVID-19 for the Social Security Administration, and the other report establishing a definition of long COVID. Both reports converge on the single reality that long COVID definition represents all the long-term health effects of SARS-CoV-2. And what that really means, it really does not mean that long COVID is only brain fog and fatigue. That's sort of what's hardwired in the public imagination or public discourse. Long COVID represents all the long-term, it has to be long-term health effects, conditions or health conditions that are causally related to SARS-CoV-2. And that's really, really very, very, very important. So what about sort of a long COVID in the broader context of the post-viral illness? Well, we really know that SARS-CoV-2 is not, as a virus, is not unique in its ability to produce post-viral illness. We've actually have observed for a long time that even people with influenza, as we touched upon earlier, actually some of them also develop post-acute manifestations and long-term illness. Measles can lead to subacute sclerosing panencephalitis. EBV can lead to multiple sclerosis. There is a post-Ebola syndrome, post-polio syndrome, and MECFS, or myalgic encephalomyelitis, and chronic fatigue syndrome is also thought to be triggered by a viral illness. And there's also substantial overlap between long COVID and some of the manifestations of long COVID, post-hospitalization and post-ICU syndrome. Now, Ben, can you please share your findings with us on the prevalence and phenotypes of long COVID?
Yeah, I'm very happy to share the finding from Beijing City. Working together with Beijing CDC, and we have completed a community-based cross-sectional study conducted in 16 administrative districts in Beijing City. Over 12,000 participants were recruited in this study, and we found that the 78% of the population ever experienced long COVID, and 5.1% of them have persistent long COVID. And we found that there are the main phenotypes of the long COVID. And the most common is the musculoskeletal symptoms. These patients have fatigue, muscle weakness, and myalgia and joint pain, and followed by neurological symptoms such as brain fog, headache, cognitive impairment, dizziness, and spirit disorder and taste disorders. And out of that is respiratory symptoms such as cough with sputum, shortness of breath. And at last, some of them, about 1/4 of them, have the symptoms of cardiovascular diseases, such as palpitation, chest pain, and bradycardia. As from the very beginning of the SARS-CoV-2 pandemic, we have built the follow-up cohort, and we have followed them for over 4 years. And we found that the optimal recovery window is between 3 months to 6 months post-infection. And we also found that some of the patients even have the long COVID symptom persistent up to 3 years after infection. And we do have the lung function and the lung image of the patients infected with Omicron after 1 year post-infection. And we found that some of them have the reduced primary ventilation and diffusing capacity. And these primary function is also have the imaging disorders of these patients.
So we're going to talk now about the burden of long COVID. So you may be asking now, okay, so is this really a problem, and how much of long COVID is out there in the community? So estimates vary, but the most recent estimate came from a study that we did with the Institute of Health Metrics and Evaluation at the University of Washington in Seattle. We're estimating that around the world, there are about 400 million individuals who've been impacted with a long COVID. And how much of a problem is this for the economy? It's actually a significant problem. We also estimate that it costs the global economy about $1 trillion per year That's really equivalent to about 1% of the global economic output. That's really sizable, significant for the global economy. And those are costs related to care for long COVID, related to the fact that some people cannot really maintain full employment, et cetera, et cetera. So when you total all of these different costs, the burden of long COVID represents a significant economic drain on the global economic output. So, what are the sequela of concerns? When we talk about long COVID, what are we really, really concerned about? So, I'm going to review them very quickly here, including cardiovascular concerns or cardiovascular disorders, diabetes and hyperlipidemia in the context of long COVID, kidney disease, neurologic manifestations, and gastrointestinal disorders. So, first of all, cardiovascular disease. When people get SARS-CoV-2 infection, most people recover really quickly. But some people can experience some cardiovascular problems in the acute phase, but also in the post-acute phase. And those are not limited to just arrhythmias or fast heart rate, tachycardia, or in some cases, bradycardia or slow heart rate, but also various manifestations, including myocarditis, including heart attacks, and blood clottings. We also found and have been now reports across the literature from the US, from Europe, and elsewhere, increased risk of metabolic dysfunction after SARS-CoV-2 in the sense that some people manifest with new onset diabetes after SARS-CoV-2 infection. That's also represents one of the facets, one of the components of long COVID, an increased risk of hyperlipidemia or dyslipidemia in the post-acute phase of SARS-CoV-2. Now, why is this really happening? Why would a respiratory virus like SARS-CoV-2 in some individuals lead to increased risk of diabetes and dyslipidemia? I don't think we really fully understand that yet, but it's very, very clear that in some individuals, they manifest with new onset metabolic problems, including dyslipidemia and including diabetes. And in some individuals, also, they manifest with increased risk of kidney disease, including increased risk of chronic kidney disease, and then some decline in GFR, or estimated glomerular filtration rate. When we try to evaluate this, the literature points to about 2 to 4 milliliter per minute of loss in eGFR in the year that follows the initial infection with SARS-CoV-2. That really represents almost the kidney aging about 4 years in the span of just one. So some people like to conceptualize infections or repeated infections as a tantamount to accelerated aging. When you get exposed to these infections, it kind of pushes you along the timeline of aging and sort of pushes your kidney forward in terms of aging. We think that's really an interesting concept for people to think about as infections as a risk factor for accelerated aging. We also see in the context of SARS-CoV-2 infection that some people come back to the clinics with mental health problems, with anxiety, depression, and other mental health conditions, and also neurologic sequela, including strokes, in some cases TIAs or transient ischemic attacks, and in some cases headaches, new onset seizures, sleep problems, and various other neurologic manifestations. And also GI manifestations, gastrointestinal manifestations in the form of nausea, vomiting, in some individuals, constipation, or symptomatology that resembles a great deal irritable bowel syndrome. So, now you may be asking, okay, well, this is all probably relates to the first infection, and how do people fare vis-a-vis repeated infection, a second infection or a third infection? And the answer is really clear from the literature. There's now have been more than 20 studies trying to examine the effect of a second infection or a third infection. And the results all point in one direction, that reinfection is consequential, is not totally benign. It may be actually milder than a first infection, but people can still get long COVID after a second infection. They can still get long COVID after a third infection. So even people who have been, vaccinated, and people who have been, had one infection or even two, a new infection, be it a second or a third or fourth, actually contributes additional risk, and they can experience either de novo, new onset long COVID, where they did not have it before, or exacerbation of underlying long COVID. They've had long COVID before, and maybe it was under control, or maybe it was very mild or mild, and they get reinfection, and that actually triggers exacerbation of their underlying long COVID. So reinfection is consequential in two forms: either precipitation or resulting in de novo long COVID, or exacerbation of the underlying long COVID. So how long is long COVID? Well, long COVID is really long. When we and others sort of try to look at patients over the course of many years, it's very very clear that the lion's share of long COVID problems actually happen in the first year, but some people still experience problems or new onset disease in the second year or even the third year after an infection. Now, we need definitely longer term studies to try to help us understand what happens at 5 years, what happens at 10 years after those initial infections, but those obviously are not available yet. Now, has the risk of long COVID changed over the course of the pandemic? And the answer is a very clear yes. The original wave or the ancestral SARS-CoV-2 was associated with the highest risk of long COVID. And that risk declined in the Delta era somewhat and actually became even less, but not null, not zero, in the Omicron era. And it's very, very clearly the risk is lower among vaccinated individuals and actually declined over the course of the pandemic with the evolution of SARS-CoV-2 itself. So two key factors that have actually resulted and decline in the epidemiology of long COVID. One is the evolution of the virus itself from the ancestor strain to Delta and to Omicron. And the other one is the reintroduction of vaccination. These two together are the primary drivers that have resulted in significant decline in the incidence of long COVID. But that even though now it's much lower than before, it's definitely not zero. So when we think about long COVID, what are the impacts of long COVID that we really think about? We think about, not only individuals get impacted by long COVID and they have, all these clinical manifestations that impairs their ability to work, but we also think broadly about the impact on communities. These people live with families, they live with friends, so the impact on the people around them could be profound. We also think about the long-term health trajectory in people with long COVID and what would long COVID morph into a chronic disease and disability. We're thinking a lot about the downstream implications at 10 years and more of people with long COVID. The impact on life expectancy. Will people with long COVID have a shorter life expectancy than people who did not have long COVID? So in other words, does long COVID itself really shortens people's life and reduce their life expectancy? We worry about development and educational attainment in kids with long COVID. Are they able to matriculate at school? Are they able to do well in sports and other things? Develop friendships, maintain friendships, all these different things that kids are supposed to do in their development years. And when they have long COVID, we worry about their ability to attain all these metrics. There is a significant concern about how health systems are actually dealing with long COVID worldwide. We've talked about the economic implications of long COVID in terms of labor market and productivity of individuals, the impact on sustainable development goals. These are global metrics that we're all trying to achieve by 2030. And then, long COVID itself may actually represent a significant strain on our ability to achieve sustainable development goals and the broader social implications of long COVID. Now, Ben, can you please tell us or describe some of the challenges that are faced when trying to diagnose and manage patients with long COVID?
I think the most challenge is that what test can we do to make the diagnosis of patients suffering from long COVID. The patients usually ask the questions, yes, am I sick? And what illness do I have? Some of them know the definition of long COVID, but most others do not know. They only have the complaints, the repeated symptoms, such as I mentioned, the fatigue, shortness of breath, or brain fog. They always think they got illness, but they do not know what the disease they have. And not only the patient, but also many doctors, they also do not know the diagnosis of the patient if the patient come to the clinic. So it is usually the story that the patient go to the clinic again and again, and the patient go to different hospitals and to see many doctors. But always the answer is, no, I do not know what your problem is. So this is the most challenge, and this is the most problem of the patients faced here in China. And the second problem is that even the diagnosis is made of long COVID, but the clinicians do not know what treatment they should give to help the patient. So both the doctors and the patients do not feel very happy about the situation. I think this is the most unmet need of this patient. There are many we do not know about the mechanism. We do not know the optimal diagnosis and the optimal treatment of the long COVID. Although there are so many difficulties, but we are clinicians. We have to do something to help our patients. At the beginning, our departments, our primary and critical care, open the clinic. We want to help our patients, but we understand that our single department cannot do help the patients. So, early beginning of this year, in our hospital, we have the multidisciplinary clinic, and the clinic is open by appointment in one afternoon. And doctors from pulmonology, cardiology, neurology, and psychology, and traditional Chinese medicine, and rehabilitation specialists, we work together, and so we listen to the patient's complaint, and we try to make the correct diagnosis, the differential diagnosis between long COVID and other symptoms. And we work together to try to give the solutions to such patients. Some of the patients get the traditional Chinese medicine, and some of the patients get the rehabilitation therapy, and most of them have the relief of symptoms, but the relief of symptoms is very slow, and many patients came back to the clinic several times. And after half a year working in the clinic, our clinicians have more experience. We do want to help our patients in our hospital. Yeah. Can you tell us about the data available for antiviral in the management and preventions of long COVID?
Yes, Ben. So I'm going to talk a little bit about sort of the mechanism first, try to help us understand sort of like why maybe antivirals may actually work in the context of long COVID. So mechanisms of long COVID first include viral persistence. This idea that most of us, when we actually get SARS-CoV-2 infection, are able to clear the virus and get rid of it completely, and it's all gone, it's just totally gone. But in some individuals, they may actually experience what we call viral persistence, the idea that the virus or remnants of the virus persist in quote unquote immune privileged sites, and then they provoke chronic inflammation and subsequently a state of disease. The other hypothesis is that it involves immune dysregulation, immune dysfunction, the idea that people, when they get infected with SARS-CoV-2, their immune system, their immune response goes awry or is dysfunctional, either in the form of autoimmunity or other facets of immune dysfunction, leading to a state of disease. The third hypothesis relates to microbiome dysbiosis, this idea that within us there are actually more bacterial cells than human cells. And when we get sick, these bacteria also get sick, and maybe they don't fully recover from SARS-CoV-2, and then therefore impacting human health and leading to a chronic state of disease. And the fourth hypothesis relates to the microclotting or clotting, this idea that in some individuals, there is, in the context of SARS-CoV-2 infection and acute inflammation, there is activation of complement pathway and other moieties or other mechanism that leading to endothelial inflammation of the lining of the blood vessel, and formation of clots, and subsequently impede blood flow to distal tissue, leading to hypooxygenation or reduced blood flow and subsequent organ dysfunction. And there is neuronal inflammation, I'm going to talk about this in a bit, and mitochondrial dysfunction. Specifically, when it relates to neural inflammation or neural involvement, SARS-CoV-2 is actually had been harvested or had been isolated from brain tissue in individual who died from either SARS-CoV-2 infection or actually down the road several months later from something else. So very clearly that the virus is able in some individuals, especially individuals with severe disease who've been in ICU, on a ventilator, et cetera, they actually may experience the presence of the virus in their brain. In addition to that, there's actually plenty of data now suggesting that SARS-CoV-2 infection induces a state of inflammation and provokes activation of the microglia, or these small immune cells that are present in the brain that are supposed to actually protect the brain. They become inflamed, subsequently leading to manifestations like brain fog, et cetera. Blood clotting can also happen in endothelial inflammation, and blood clotting can also happen in the brain. Microbiome dysbiosis can also affect neurologic function and brain function. There's also evolving line of evidence suggesting hormonal dysregulation or dysregulation in the hypothalamic pituitary axis, adrenal axis, leading to, in some individuals, to low cortisol, and subsequently some manifestations related to long COVID. So now, how do we prevent long COVID? The answer on this is very, very clear. It comes from actually more than 40 studies done in the US, in China, in Europe, and elsewhere in the world. Vaccines actually reduce the risk of long COVID. That's really has been very clear. Study after study in people who have been vaccinated versus people who have not been vaccinated. People who have been vaccinated actually have less risk of experiencing long COVID. Now, does the risk go away completely with vaccination? No. Vaccines do not eliminate the risk of long COVID, but they substantially reduce the risk of long COVID, including its various manifestations, its cardiovascular manifestations, its pulmonary manifestations, and in all the other manifestations of long COVID. And antivirals, when taken in acute phase, reduce the risk of long COVID. Now there have been data on multiple antivirals. First of the most commonly used, nirmatrelvir, in analyses evaluating people who have been treated with nirmatrelvir or in the acute phase of SARS-CoV-2 infection, and then subsequently evaluating the risk of long COVID. People who've been treated with that antiviral with nirmatrelvir have actually less risk of developing long COVID than people who have not been treated during the acute phase. Now, we have to mention here that the classic indication is people who are of advanced age, 60 or 65 years of age or older, or have at least one medical condition that predispose them to develop severe SARS-CoV-2 infection. So, antivirals are not for everybody. Generally, they are indicated for individuals who are of older age and have a medical condition that predispose them to severe SARS-CoV-2 infection. In that subset of patients, intake of antivirals, for example here, nirmatrelvir, reduces the risk of the post-COVID condition or reduces the risk of long COVID. And then that's not the only antiviral that actually has been shown to reduce the risk of long COVID. Multiple studies have been done also on other antivirals, including molnupiravir, and then it had been shown to reduce the risk of long COVID as well, including one randomized controlled trial called the Panoramic trial, which they evaluated the 6-month follow-up of people who've been treated with molnupiravir and people who've been treated with placebo. And clearly, people who've been treated with molnupiravir had, at 6 months in that randomized controlled trials, less risk of developing long COVID. There is some data also on remdesivir, and especially in people who have severe SARS-CoV-2 infection, and its ability to reduce the risk of long COVID. So to sum up prevention of long COVID, there are a multi-pronged approach, including vaccinations. Vaccines reduce the risk of long COVID. And in people who are of older age, 65 years of older, or have a medical condition predisposing them to severe COVID-19 illness, the use of antivirals may also reduce the risk of long COVID. So what about treatment now? So there have been a few studies evaluating the effect of nirmatrelvir in people who have already established long COVID. Those studies have so far yielded null results, meaning that in people who have established long COVID, who've already had long COVID, treatment with an antiviral does not seem, at least with the current evidence, does not seem to ameliorate symptomatology of long COVID. So the verdict on this is still actually not completely out yet. More studies are being done to sort of evaluate whether dose or duration of treatment or a combination of antivirals really could actually result in better control of long COVID symptomatology. So while the randomized evidence that we just talked about has so far did not really show a reduction in the symptomatology of long COVID after using antivirals, more needs to be done in this area to help us evaluate whether a higher dose, longer duration, or a combination of antivirals would reduce the risk of long COVID. Now, Ben, what are your thoughts on the future directions for long COVID to help improve our understanding of the condition and outcomes for patients with long COVID?
Sure, yes. Thanks, Ziad. As Ziad mentioned, there are many unknown about long COVID. So these are what we want to do is to do in the future research. I think the most important is that we have to figure out the underlying mechanism of long COVID. The mechanism research data will give us the optimal diagnosis criteria of long COVID. And after we make the correct diagnosis, yes, we want to answer the question, what kind of treatment for long COVID? If we know more about the mechanism and if we know more about the treatment target of long COVID, we have to figure out the right population, the right dose, the right time, and the right course of the treatment for long COVID. Except for antiviral, there are other options for treatment of long COVID, including the host immune modulations and the rehabilitation program for long COVID. And we are doing clinical research to study the traditional Chinese medicine for Chinese population suffering from long COVID. But I think there's a long way to go to find the exact mechanism, the optimal diagnosis and optimal treatment for those patients suffering from long COVID.
And yes, Ben, thank you. So and also, I think there is quite a bit that needs to be done in the policy space to help us advance our understanding of long COVID, including really how do we continue to prevent long COVID in a much better way? How do we support people who have been impacted by long COVID? Access to care for long COVID, quality of that care, and equity considerations. We think, and this is really important in the context of this program as well, professional education and training of the workforce, of physicians, of providers, of nurse practitioners, of the larger community of healthcare providers who need to also understand what long COVID is and how to deal with a patient who has long COVID in their clinic. Public health communication is really important for the public to be aware of long COVID and its ramifications. And then we definitely also think that there need to be a coordinated interdisciplinary approach in terms of research for long COVID, that no one discipline can solve it. Immunology alone or virology alone or clinical epidemiology alone cannot really solve the complex riddle of long COVID. It's going to require literally, people are coming from, different disciplines and sitting together and working together to help move the ball forward and understanding long COVID. There is quite a bit of need to build consensus around definitions and clinical endpoints for long COVID, a global coordination in terms of how do we address long COVID together as a global community. There need to be professional societies for long COVID to try to help us literally promote a better understanding and promote all these other policy goals. And really the key in my mind all the time is really preparedness for the next pandemic. SARS-CoV-2 is not unique in its ability to lead to long-term health effects or long-term manifestations. And very, very clearly, other viruses can and do that as well. And we worry about a future pandemic or a virus, whether it's a 2030 or 2035 or 2040, that will also result in a wave of disability and chronic disease. And we need to be prepared for that. We cannot be caught unprepared for the eventuality of a pandemic and the likelihood that it will also produce in its wake another wave of chronic disease and disability. So in conclusion, I really hope that me and Ben communicated to you that long COVID is indeed a multifaceted disease that can affect nearly every organ system. But the human and economic toll of long COVID is actually significant. More than 400 million people have been impacted with long COVID across the globe, and it costs the global economy $1 trillion per year. That's 1% of our total global economic output. That the risks of long COVID are increased by reinfection. That reinfection is not inconsequential. Reinfection can trigger either de novo long COVID or exacerbates underlying long COVID. And long COVID can be reduced by vaccination and antivirals in those who qualify for them. Basically, older adults with comorbidities that predispose them to severe COVID-19 illness. And we really think long COVID is a global problem. It requires a coordinated policy and research strategy. Thank you very much. And I really would like to thank Ben for the insights and the great discussion that we've had talking to you about long COVID.
Thank you, Dan.
And I wanted to thank the audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.